we're looking at inflammatory lung disease and sometimes how it can mimic otherwise conventional ARDS. So we see a lot of ECMO-dependent SRF with ARDS. Some have a relatively clear cause, pancreatitis, meningococcus sepsis, or being run over by a bus. But others don't, and a lot of SRF referrals are initially labelled as ARDS secondary to, well, a pneumonia. And sometimes it is. This is Legionella. And the thing to point out that when you have, we think, an ARDS secondary to an underlying pneumonia or a conventional ARDS, you get this gradient pattern between the front, the ventral area, which is largely black, and the bottom area, which is largely white. Okay, so it goes black, then grey, then white. And there are no spared areas at the bases. So that looks like a conventional ARDS. This is an aspiration pneumonia from a couple of weeks back. And again, the CT shows this characteristic black at the front, white at the bottom, without any bits being spared at the bottom. So we think that's a sort of conventional ARDS picture. But of course, not everything labelled as pneumonia and bad ARDS is actually such. And what we want to do is present 4 cases of mostly ECMO-dependent SRF, most of whom were initially labelled as having pneumonia leading to an ARDS, who actually don't think have a normal pneumonia leading to ARDS. Some of the 4 can be forced into one of the classical diagnostic boxes, but some are a little bit more difficult to place. And right at the end, we'll give you an overview of our diagnostic approach to that latter group, a little bit more difficult to put into a box. So we'll start with the first one, who's 57, and she starts out with 6 months of joint and wrist pain in the background. And then she develops 6 weeks of cough, fevers, and progressive shortness of breath. And also she gets aches, specifically over her shoulders and over her upper thighs. And she goes in locally with this X-ray with a CRP of 200. This is on, just note the date, this is the 6th of January. And you can see it's abnormal, isn't it? There's bilateral, bibasal shadowing, which is subtle, but it's definitely there. And she was in HIV, and she wasn't in heart failure. So all those common things had been largely excluded. And she was labelled as having an atypical pneumonia. And when you see people being labelled as atypical pneumonia, I think that's a warning sign that something isn't quite right, because it means the clinicians think that they've got a pneumonia, but then they think at the same time that isn't really a pneumonia, so they put it into the atypical pneumonia. So that's being labelled as having atypical pneumonia is I think, a sign that something isn't quite right. So she was treated as that. She had some conventional HAP antibiotics, community-acquired pneumonia antibiotics. But from the 6th to the 17th, she deteriorated and eventually got intubated on the ward with a CRP of 410. And that was about sort of 11 or 12 days later. And you can see that her parenchyma has got progressively worse with bilateral infiltrates. And here's her CT. And it's different from those 2 CTs I showed you earlier. It has a sort of gradient from front to back, but you can also see it looks moth-eaten. And see how these little bits have been picked out. And if you look at those in detail, this is the perilobular pattern. Okay? And these little things are the spared secondary pulmonary lobules. So when you see these areas of sparing, that suggests that what you may have is a thing called an organized pneumonia. And an organized pneumonia is one of the interstitial lung diseases, and it commonly presents like this, and it commonly moves rapidly from this sort of pattern into a more sort of acute interstitial pneumonitis pattern where it all sort of goes white, and then you lose that initial pattern. But you can just see the remnant of it in her because you've got these spared secondary pulmonary lobules, and that's an important pattern to recognise, we think. So there we were. We thought she had an OP-AIP pattern on the CT. She got that long history, no response to antibiotics. She had the arthralgias, the myalgias, the malaise. And the other thing was she was in exquisite single organ failure. So everything was fine, but for the fact she was hypoxic. It wasn't as though she was... If she had got to being intubated and that was a strep pneumonia, she would be more unwell, and she wasn't. She was in single organ failure. So I'll hand over to Nina to do the next bit.
So we thought that she had, as Boris has said, an organising pneumonia into acute interstitial pneumonitis. most likely given her extrapulmonary symptoms and the prodrome. And I think the collateral history here is really important. So this diagnosis was made fresh when she presented with her cerebrospinatory failure. But actually it's very useful to speak to the family about perhaps what's been going on at home, because there are often clues that may fit with your decision-making and diagnostic workup. So we felt she had a dermatomyositis, which many of you will have heard of. But this particular group of conditions sits within that. So they are characterized by myositis-specific autoantibodies, which are called that because they are involved in these myositis-type syndromes, and they focus or target the tRNA synthetases, which are cellular enzymes involved in protein synthesis. And they are particularly associated with this rapidly progressive organizing pneumonia into AIP pattern. And often in this condition, it is the lung that defines their outcome. So we had a clear bowel from her local hospital. We obviously sent off our own data set, including our own immunology. But given our high index of suspicion, we put in place a remission induction, which for us is 3 grams of methylprednisolone, but not as monotherapy, in addition to cyclophosphamide, because unless you switch off that inflammatory process, they will then accumulate irreversible fibrosis, which then ultimately determines their outcome. So we give them combination therapy up front. And we are very pleased with her CRP, and this is a very typical CRP curve in someone with a pure or dominant inflammatory phenotype, and you can see how quickly it falls with immunosuppression, and that's obviously the methylpred. But things don't always go according to plan. So soon after that, she developed abdominal distension, and you can see the dilated loops on a plain film. Although interestingly, look at her. We were pleased with her chest, certainly, but her CRP started to go up. And bear in mind that she is heavily immunosuppressed. The cyclo's about to bite. But we work with a fantastic team. This is CT just demonstrating once again the dilated small loops of bowel. So she went on to have a laparotomy, and again, just the importance of a multidisciplinary approach to these patients. You can see this is her initial induction, this is her obstruction, and then with close monitoring, active surveillance, and multidisciplinary care, you can see her CRP remains down. And her clinical progress was one of improvement, and this is just a series of plain films, and you can see the resolution, which you'll appreciate just on plain film. And this is actually a picture of her. This is with her consent. We get to know these patients quite well because obviously we meet them when they're on the intensive care unit, but of course continue to follow them up. And she's done extremely well. She's just on mycophenolate, no steroids alone, and has had no further relapses, and clearly, as you can see, has no oxygen requirement, and has progressed and responded well. And just to point out that these are a really important group, we see this not infrequently. So often in these patients with an AIP, that's one of the things that we'll commonly think of. But because of the nature of these antibodies, which are highly specific and disease-associated, they actually don't come up on an ANA. They often will be missed on a standard ANA because they're not nuclear, they're cytoplasmic. So that's the importance of sending off what we call a myositis-specific panel. And you can see that we don't actually wait for it to come back if we feel the setting is right. And you can see that this lady here is PL12 positive. Interestingly, she also has a rheumatoid factor and a CCP, but I'm sure they are an epiphenomenon as opposed to diagnostic in their own right. So really just to recap the importance of the antisynthetase group of syndromes, they're often amyopathic, so they may have subtle myalgia, but it's not profound. It often goes under the radar in terms of diagnoses, and just really to highlight the importance of thinking about this group and the appropriate immunology with respect to confirming the diagnosis. So I'm going to hand back to B. Oh, so clues there, as I just said.
So that's the antisynthetase, and they're commoner than you might expect. Case 2 is a 62-year-old who presented January of last year, initially to outpatients. And again, she had flitting arthralgias, occasional epistaxis, and some weight loss, and in the background of her setting of progressive shortness of breath. Here's her outpatient scan. Doesn't particularly well, but take it from me, the top has got emphysema, and she was a smoker, and the bottom has got fibrosis. And I'll tell you, this is a fibrotic NSIP pattern, or fibrotic non-specific interstitial pneumonitis pattern, and that's sort of what you might expect in, say, rheumatoid. There's traction dilatation of the airways and fibrosis. She indeed did have a positive rheumatoid factor, and in that setting, she was given a diagnosis of rheumatoid-associated interstitial lung disease, and that's not uncommon. She wasn't actually treated with anything, and then she presented on the 17th of March with increasing breathlessness, fever, sweats, a dark urine, a creatinine which had gone from 80 in clinic to 304, dropped her hemoglobin a bit, and her CRP was up at 141. And here's her X-ray. And her X-ray had deteriorated so that she's got unilateral infiltrates on the right and a little bit of lower zone infiltrate on the left. So again, she was treated as though she had rheumatoid-associated interstitial lung disease and were given some antibiotics. Not unreasonably, she had a fever, but she didn't get better, she got worse. Her CRP went from 141 to 188, her creatinine got worse, and this was in a setting of mild hypertension. She wasn't hypotensive, it didn't look as though she had an ongoing bacterial pneumonia, and you could put the creatinine down to sort of underfilling or poor cardiac output. Her hemoglobin drops, and she desaturates on the ward. Interestingly, along with the creatinine of being 311 with a normal blood pressure or even high, she had an active urinary sediment, suggesting that her renal function there was something intrinsic to the kidneys. And here she is intubated on our intensive care unit, and that's only 2 days after admission. And you can see the pattern is odd, isn't it? It's got bilateral infiltrates. That's a little odd. And so it was a Sunday. We didn't have any access to immunology. Her renal function was going off, and she was progressively getting worse. And so this is her sequential lavage, and it's a good test to do if you can get away with it. And it goes from bloody to more bloody to very bloody, and that's indicative of a diffuse alveolar hemorrhage. So we were stuck with, well, not stuck, we were left with this diffuse alveolar hemorrhage in that setting. So Nina.
So she clearly has a pulmonary renal syndrome. She has a very interesting phenotype actually, because she's got a background of ILD. But we felt, given her disease behaviour and the sequence of events, that she probably had an MPO-associated, ANCA-associated vasculitis. So just to give you a very brief overview, the ANCA-associated vasculitides come down to usually two, for the purposes of today's talk, and it's either PR3, which is what we used to call Wegener's, or MPO, which is called microscopic polyangiitis. We had a high index of suspicion again in her because we knew that she had a pre-existing ILD, and usually it's only the MPO positive ANCA-associated vasculitides that get an ILD. The GPAs don't usually get a fibrosing lung disease. But it's interesting that she flitted between having an ILD to having a DAH, which is not something that we've come across before. But nonetheless, she seemed to have a pulmonary renal syndrome associated with now a life-threatening diffuse alveolar hemorrhage. And our admission induction in her was our standard AAV protocol, so 3 grams of methylpred followed by about 0.5 milligrams per kilogram, and plasma exchange, which we do on a daily basis. And those interventions for an active DAH are quite important because usually the other drugs, so for example cyclophosphamide and rituximab, take time to work. So you need to bridge the gap before they become effective. However, this was sort of Sunday afternoon. Overnight, she had deteriorated, although she'd obviously have the steroids and Plex, but still, often we see they almost get worse before they get better, before the immunosuppression kicks in. And we made a decision in her collectively as a group that even though she had a pre-existing ILD, we felt that her deterioration was due to the DAH. And in our experience, we actually feel that the ECMO provides an advantage in those patients that have life-threatening diffuse alveolar hemorrhage. So we opted to offer her and put her on ECMO. B's just going to run through those couple of X-rays.
So this is a scan from Monday, the X-ray from Monday, where you can see she's got bilateral infiltrates. They're worse, and it looks a little bit like blood. It's central, it's diffuse, and here's her CT. A CT is a little bit difficult to interpret because she's got obviously her upper lobe emphysema and she's got a fibrosis at the bottom, but on top of that she's got plonked her DAH, her diffuse alveolar hemorrhage, and you can see it's typically central, it's consolidated, and you can see how it tends to spare the extreme edges. So when you see that consolidation and the sparing of the edges, always worry about blood.
So we got her ANCA, and we have a very good relationship with our immunology lab, even though it's at King's and we're at St Thomas's. But a day or two later, her ANCA came back, and you can see that it confirms it's very, very high at 134. And she slowly, over the next few days, if you just keep an eye on the timelines, that's 23rd. This is her CRP trends, and again, what's so satisfying in these patients is they often go into it with a CRP that goes like that, but as soon as you give them remission induction, their CRP falls really very, very quickly, so 24 to 48 to 72 hours. And you can see that her creatinine again peaks there, and this is the importance, I think, of offering these patients combination therapy right up front, because what you're trying to do is limit the more persisting permanent organ damage. And actually she regained full renal function. She's not dependent on any form of renal support. Our induction is, as I say, combination, so IV methylprednisolone, Plex in those patients that present in this life-threatening way, cyclophosphamide, in addition actually to rituximab, because there's some evidence actually that combination low-dose cyclophosphamide in this group of patients, in addition to the rituximab, offers them additional efficacy. And also she had a pre-existing ILD, which we were really keen to lock down. And she again continued to do really quite well over a relatively short space of time. You can see her x-rays clear. So really just to highlight the importance that we often see patients that are thought to have rheumatoid, but rheumatoid factor can be present in lots of situations. It's often a false positive, can be present in connective tissue diseases, but really just to highlight that not all rheumatoid disease is pure rheumatoid. And we feel that pre-existing fibrosis in these cohorts of patients, i.e. these inflammatory phenotypes, should not represent an absolute contraindication to ECMO. And DH very often looks just like a really, really bad pneumonia, but the imaging is different, the disease behaviour is different, and it's certainly something to consider.
So the third patient is this guy. He's 22, and he gives an odd story. So his mum said that when he was 14, he was admitted to ICU with special asthma. She said the doctors said it's special because they couldn't hear any wheeze. And he went and had some steroids, and then he got better, and then he was fine for 8 years. No inhalers, nothing, no cough at night. So it didn't really sound like asthma at all back then. He then goes and gets a job in a bar and gets some money and starts smoking quite heavily. And then 2 weeks after that, he starts coughing up green sputum over a period of up to 2 or 3 days, and it's associated with fever and sweat. And he gets admitted, and look at him, he looks like he's got something going on. He's got a CRP of 326, he's got a white count of 30, all neutrophils, and he's got a temperature. And here's his coming in scans. This is the 4th of July, and he's got bilateral infiltrates. And if this was a staph pneumonia, which it could have been, he would have been flat on his back, but he wasn't flat on his back from his blood pressure or from multi-organ failure. He was just very short of breath and hypoxic. Things move rapidly. This is the next morning at 11:03, so he's gone bad. And so what would you think about that there? You think, well, are his valves falling apart? Is he bleeding? Is it PVL staph? But it didn't really fit with any of that. And then 2 hours later, he was unventilatable. And here is his retrieval scan. He's got airless lungs. And then this happens. So his eosinophils start peaking up until about 6. And with that, his CRP goes up to 300. And he's definitely stuck. His lungs remain white. So Nina's going to take over from this.
So we felt initially that he had an acute eosinophilic pneumonia, and I have to say, I think certainly personally in terms of our practice, this cohort of patients, these eosinophilic phenotypes, are probably some of the most interesting that we come across. So we gave him standard induction, 3 grams of intravenous methylprednisolone. Because it's an AEP, we didn't feel the need to give him any combination or additional immunosuppression. And he originally did very well. If you just watch his, and actually CRP and the peripheral EO counts are really good real-time biomarkers in these sorts of patients, in this cohort of patients. So you can see this is his rising EO count, and it falls very nicely. They almost run in tandem. And then actually 3 grams of methylpred, and an AEP is typically, characteristically, very, very steroid responsive. But actually, if you can see here, his EOs came down, his CRP fell very nicely, and I remember this very clearly because I got a call on Sunday morning. He's about to go back because he's so much better, because that's very typical for an AEP disease behaviour. But then someone noted his count, Yeah, and they were going up. So this is what we called the bounce. So we pulled him back, we took him back up to the unit, and we repulsed him. So that's his second round of pulse methylpred, and you can see his CRP again falls nicely. But that's very interesting, and this is a series of X-rays just really demonstrating how quickly these EPs respond to steroids. But what's unusual about him, which I'll come back to in a moment, is typically, as I said, the AEPs are classically described as presenting with a fever, with an initial leukocytosis that is neutrophilic. So when they first present, they have a fever, they have a neutrophilia, they have a very, very high CRP, and they are understandably treated as a mnemonic process. But they rapidly progress over hours, so 24 to 48 hours. So again, the disease behaviour, I think, is very interesting and allows you to watch these sorts of patients and get a sense of what may be driving their SRF. And so very quickly intubated, and then the eosinophilia comes out, the peripheral eosinophilia. So it often comes through mild and then moderate, slightly later on in their presentation, which is very similar, exactly what happened to him. However, he's different. He's not purely an AEP, because actually Boris took the history, he took a very good history. The grandfather apparently had been investigated for some GI symptoms that they thought were eosinophilic in nature, so he had an eosinophilic colitis. He had this previous episode out of nowhere of having almost life-threatening severe asthma. And then the eosinophil disease behaviour, the fact that they bounced on such high doses of steroid, is highly unusual. So we asked, which is really what that shows, so we asked our haematologists, because an important group not to miss is those that either have idiopathic hypereosinophilic syndromes or a myeloproliferative eosinophilic syndrome driving their organ damage. And we have this ongoing debate with our haematologists. He had a bone marrow, he had his cytogenetics, both of those were normal. And understandably, their feeling was that he did not have a hematologically driven eosinophilic syndrome, but that it was reactive. So we feel actually that he doesn't really fall into that box, but he's got a disease behaviour that almost overlaps with HES. So we would describe him as an EP-HES overlap. He's done very well, actually. He was only 18 when we first met him, but he has remained symptom-free and off treatment for many years.
And this is the last one, who's slightly more tricky. So she's 43, and she's fit and well, apart from a bit of a nut allergy. And then she gives this 3-day history of sort of low back and left upper leg pain, and then just gets really unwell, collapses at work, and comes in with a systolic of 42, good going septic shock, and a temperature. Anyway, they scan her and they do various things, and I think it was a strep. And they come to the conclusion, I think it was right, that she had a piriformis pyomyositis with good-going septic shock. So they give her some antibiotics, fluids, NORAD, IVIG, and she actually does pretty well. So her CK being 5,000 comes down, her CRP, which was up at 537, comes down, her white count, which was up, comes down. And so this is 11/11, so this is 3 days after she presented. She's off inotropes, CRP and CK down. She's doing well. And then she's extubated, and she's sitting on the ward, and then her oxygen sats start dropping, and then she starts developing these sort of bilateral infiltrates. She's sort of 8 litres positive, but systolic was 43 when she came in, so that's so they gave her some frusemide, but that didn't do anything, so they ventilated her. And they said, what the hell is going on? So, well, is this sort of ARDS secondary to sepsis? But it's a bit late, isn't it? And then 3 days in, they put her on some meropenem, understandably. She develops this urticated macular rash. And then her eosinophils go up to 0.8, but albeit with a very high total white count. And she has a skin biopsy, which of course we don't get back yet. And her CRP starts to go up. And then she gets intubated, and then she can't be ventilated, and then her CO2 clearance goes up, and then she gets retrieved on ECMO. So just to look at her imaging, this is the scan they did when she walked in septic shock. So it captured the lungs, but the lung parenchyma is normal. And this is her coming in on retrieval. You see, she's got. I don't have the intervening films, but by report they just show gradually progressive infiltrates, and of course she's got bilateral infiltrates. And again, she has a completely airless body, and airless lungs to go with them. And here's the arterial phase. It's always worthwhile looking at the arterial phase of CTs, because you can see this little black bit here, and this little black bit here, and this little black bit here. So the white bits, of course, are where the contrast is going. The black bits are where there isn't contrast going. So we thought that perhaps she'd sort of infarcted bits of a lung. And we were left with this CRP of 266, a white count of 25, a slight eosinophilia. That, I think, was correct. And we thought, well, why has she suddenly gone off? Has she got some sort of pelvic collection and was sort of throwing off some sort of venous emboli, and that had kicked it all off? And was the eosinophilia sort of a mini drug reaction? So we just gave her some antibiotics and scanned her, but there was really nothing going on in the pelvis. And her CRP fell, which is good. Her procalcitonin fell, wasn't particularly high to begin with, but it fell. But then the eosinophils start doing this. See, look at them, creeping up in the background. And she was stuck. She got a little bit better, so she clears something. And here's her CT. And again, you see how it looks a little moth-eaten. There's this moth-eaten bit here, and the secondary pulmonary lobule here, and a little one here. You may say, oh, well, you're overinterpreting that. Maybe. And the other thing is, and you're not going to believe this, but it is true, that this is not volume overload. Okay? These pleural effusions have come on since she's been in, and she hasn't been run particularly wet. She didn't, her blood pressure was fine. So she was clearly worse, and so we gave her some steroids. We gave 3 grams of methylprednisolone. Good, excellent, fine. So we dealt with that. The eosinophils are down, but they're not quite completely down, and her CRP falls. So everybody's happy, and her chest X-ray gets better, and her CT gets better, but it gets better in an odd way. So it no longer has the gradient, and it's looking all patchy, and you can now see all these little spared bits. So it's looking odd. And this is on milligram per kilogram of methylprednisolone, and those eosinophils should have gone away now. Okay? They should have gone away and stayed away, but they're back. So they hit 7, and with that, her CRP goes up. So we give her 3 more grams of methylpred, and her eosinophils come down, and her CRP comes down. But then she gets worse again. And this again was on 80 milligrams of methylpred. You can see, look, they're just going vertical at 8 with a CRP which is going up, and she's got worse. Okay, her infiltrates have got worse, and her little effusions are worse as well. So on the intervening scan, I didn't show you, the infusions had gone. So this looks a little bit like an acute eosinophilic pneumonia, because with acute eosinophilic pneumonia, you do get these pleural effusions. But then why would she suddenly have that in the middle of everything else? So we gave her some ivermectin, because we always give everybody with an eosinophil some ivermectin just to cover strongyloides, although it never is. We got a bone marrow because we thought, well, maybe this was some sort of eosinophilic leukemia, but why would she suddenly have an eosinophilic leukemia just after having come in with septic shock? Anyway, so that was normal. She had negative cytogenetics, and she was stuck on ECMO, very much stuck, with that eosinophil count, which was sort of going up vertically, and that CRP on 80 milligrams of methylpred. So I'll hand over to Nina.
So this is a lady who has clearly a marked peripheral eosinophilia despite 6 grams of methylprednisolone, in addition to maintenance of milligram per kilogram methylpred. And in essence, we felt, watching her disease behaviour, that she fell into one of these very interesting inflammatory EO-driven phenotypes. She had the nut allergy. See, eosinophils have 2 real roles in life. So they are heavily involved in allergy, and they're also involved in helminth infections, which is why obviously the ivermectin went in. But she had a background of a nut allergy. She used to wear an EpiPen. It was quite significant. It wasn't trivial. Her immune system had clearly had a hit. She was overwhelmingly septic when she first presented. It seemed as though she had had a drug reaction, so it's almost a series of unfortunate events. And then interestingly, her paternal so her mother said that her paternal grandfather had died of asthma in his early 40s. She had never had any asthma prior to this presentation, so we really felt that hypothetically she had an excess IL-5 mediated eosinophilia that was associated with significant end organ damage, so primarily her lungs, but she'd had the skin. So really the question was what to do next. And as a rheumatologist, and I think this is really where combining skill sets, I hope, really optimises and pushes forward all of our practice. I want a drug that works fast, is safe, is specific, which is relevant to her, and ideally is a monoclonal. And of course, there is an anti-IL-5 monoclonal, and it's called reslizumab. And there are a number of monoclonals that are now used in severe asthma that essentially are IL-5 blockers. So we gave her remission induction with IV methylpred, but in addition to that, we gave her a single dose of IV reslizumab at 3 milligrams per kilogram. And Luigi may or may not remember this, but Luigi, we were on together. And this is how IL-5 works. So it inhibits binding of IL-5 to its receptor, and it then targets a number of actions, but importantly, reduces eosinophil recruitment to the lung. Also has a number of other effects, so it's a very good IL-5 blocker. And this is the trends in her EO and her CRP. So this is the first pulse, this is the second pulse, this is the third pulse of 500 times 3 with the reslizumab. And you can see, again, it has a dramatic effect, so the combination therapy. But on this occasion, they stay down. So her CRP stays down, her EOs stay down. Luigi gets a text from me every morning to find out what her counts are. But happily, and just keep an eye on the timeline. So this is the night, we gave it to her on the 9th of December. So the 19th of December, 25th, so Christmas Day, she had her pipes out. She spoke to her son. She's only young, actually. Spoke to her son for the first time. And then very rapidly, 19th of January, went home with actually pretty clear lung fields for what it's worth. So what was that? Clearly she had an inflammatory state that was associated with this intense eosinophilia. But again, it doesn't fit into these characteristic eosinophilic lung diseases that are described. And this is really just a narrative of what we have seen and what we feel we now recognize. And certainly EOs can be mediators of really quite profound inflammation and tissue damage in these patients within the SRF cohort. But they don't fit, this is like fresh snow, they don't fit into conventional diagnoses or diagnostic boxes. They're almost on a compass where actually you can flit and overlap and evolve in individual patients. So really, the importance of phenotype-directed therapy. So some patients may just need steroids. Some patients may need more of a vasculitis remission induction with combination therapy, and those that are more in the HES hematological setting may need cytoreductive therapy. But perhaps increasingly we may come to realise or appreciate the role of the IL-5 blockers in this group.
So I won't go over the cases because in the interest of time, but I think the important thing is, what are all these things? And we see more and more of the more and more obscure, which we can't fit into a group. We sort of want to call them this hyperinflammatory phenotype, but then Manu says we can't do that because that's already been used by somebody else. So what is it? So what we're looking for when we're in the SRF MDT is the presence of ECMO-dependent severe respiratory failure, or any severe respiratory failure, and lack of response to conventional treatment for ARDS. So they're stuck, is thing number one. And then we apply a domain-based approach. It's got clinical, radiological, and laboratory. The clinical stuff is, you don't have a known precipitant, all that precipitant is resolved, and there isn't that multi-organ failure going on. There isn't sort of septic shock, and also a known or probable autoimmune disease. In the laboratory, it's the persistent elevated CRP in the absence of an effective etiology, or having treated that infective etiology and a procalcitonin falls, an elevated and persistently elevated CRP. A normal or low or having a fallen procalcitonin, and then positive autoantibodies, especially that myositis antibody plot. Again, the importance of the peripheral eosinophil count, and we always like to have a sterile bowel if possible. And then radiologically, I've spoken about the first two, the absence of that gradient from the front to the back and the presence of that OP pattern are two of the four features which we look at for radiologically. And so we hope that we can identify these hyperinflammatory patients and then immunosuppress them depending on their exact phenotype. Not just in the more obvious, so in the diffuse alveolar hemorrhage or the ANCA-associated vasculitis, but also in the more obscure and as yet undefined. And we think it's important to have a lung inflammation service embedded within the SRF team, and this is all the rest of the SRF team who do all the work. Thank you.
That is great, Boris, Nina. Thank you very much. One thing to say before we open to sort of question, that although they seem obscure, that we actually see a lot of these cases, don't we? So when we look at the number of patients that we see every year, about 1 in 10 so 10% of the population with severe respiratory failure have mainly newly diagnosed inflammatory phenotype or autoimmune disease. So they're certainly present. Anyone, any comments or questions? Yes.
Do you do or think of doing open lung biopsy in these cases, or how frequently, or do you have any data post-mortem?
So it's a very good question. We don't have a lot of post-mortem data. I wish we did, but we don't, and I think that's a cultural thing. As far as getting biopsy, they're difficult to biopsy. I've biopsied, well, a couple on transbronchially, and they do badly on ECMO. They bleed a lot. So we don't do that, principally because it's difficult to do, principally because they bleed, but also because once you get the biopsy back, it'll show that there's a bit of fibrosis and infiltration by various different inflammatory cells, and the differential is wide. You don't really get anything back, and we sort of know that there's inflammation going on. The reason we want to do biopsy is to exclude a cancer, so we're not bashing away at a cancer. Clearly, the diffuse alveolar cell carcinoma can look a little bit like some of this stuff. So A, to exclude a cancer, so you don't keep on bashing at that, and B, of course, there's always the worry about infection. So, but no, we don't. But the other thing we used to do little snips of middle lobe via VATS, but again, we didn't really get a huge amount of information back.
Really, just to add to that, is in ILD as a whole, actually there's been a move away from biopsying and to confirm a diagnosis. It's more in those cases where you don't feel you can put together a phenotype, really because the immunology and actually the imaging is so good across ILD as a whole. So actually, I think nationally and internationally, everyone seems to be biopsying less.
Thank you. Any other thoughts? There's a question over there. Thank you.
Thank you. Very, very interesting. Maybe a silly question, but I wondered what your experience was in the context of a paraneoplastic syndrome, where obviously the etiology is that, but where there's an inflammatory presentation, and whether there is, in your kind of practice, a role for anti-inflammatory steroids and all of those sort of range. We just had a really interesting case recently. She had all the hallmarks: systemic sclerosis, initially seronegative, and then dermic melanosis, and all the kind of hallmarks. And we only diagnosed the adeno-CA of the lung through a biopsy that had been done 2 weeks before she presented. And I just wondered about the role of anti-inflammatories in that context.
Yeah, I think it's an interesting question, particularly with the sort of CTD overlaps and the myositis. So actually, you can get a JO1 in association, for example, which is one of the antisynthetase syndromes. So you can get cancer-associated myositis. But I suppose in those sorts of situations, it's always a question of what's going to kill them first. If it's their profound, overwhelming, severe respiratory failure, then we would say, actually, steroids do not carry a contraindication. They will not affect your host response such that sort of tumour surveillance then is affected. And it actually also allows you time to then put in definitive management or whatever it might be of the underlying driver. So certainly I wouldn't hold back on steroids in someone who I think had a paraneoplastic syndrome. I would avoid probably something like cyclophosphamide, but again, rituximab is quite useful in those sorts of patients that you described because it doesn't have the same sort of impact on tumour surveillance.
Okay, and the other thing to say is if you've got a polymyositis which affects the lungs, it's unlikely in the end to be paraneoplastic, if you look at it from the other way around.
Thank you. Any other points for discussion or questions in any of the cases or anything else to do with inflammatory lung disease? Yeah, there's one at the back.
Thank you for that. It's very interesting. Question was about the role of bronchial lavage and cell differential within that early. You talk about the systemic eosinophil count. Is there a benefit or a role to early cell differential? There's a little bit written on this that I've read recently.
So in outpatients, the differential white count is useful because it can differentiate between things like a UID pattern, which is a fibrosing disease, and a hypersensitive pneumonitis. So we use a cutoff of 15% for lymphocytes as an outpatient to give people either antifibrotics or steroids. In the ICU, it's not as useful, and we've found varying correlations between a bowel eosinophilia and a peripheral eosinophilia. We mainly use it to exclude infection and also to to see whether there is a diffuse alveolar hemorrhage.
Well, yeah, I agree. I think that cell differentials, particularly in the AEPs early on, one of the diagnostic criteria is a bowel eosinophilia, because usually eosinophils are tissue resident. So, obviously we're looking at the peripheral counts, but of course the question is what's going on in the tissues. So certainly early on, it's one, I think particularly in the AEPs, it can be useful because they should have, if they're a pure AEP, a bowel eosinophilia, and they may not have that peripheral eosinophilia early on. But in the others that we described, the sort of reactives, we haven't found a close association between our bowel eosinophilia and our peripheral counts. I think the other thing is it's also quite dependent on your lab. That's the other thing, because normally there should be less than 2% eosinophils in a normal inverted commas bowel. So again, I think there is perhaps a sort of lab-based issue around that, but that's our observation.
That's not to say that we shouldn't be looking harder. We're probably not seeing it because we're not looking properly.